everyone. Today's topic is limbal dermoid cyst in pediatric patient, a case report examining diagnosis, management, and surgical intervention of congenital ocular surface lesion in 9-year-old patient. It is a benign congenital choriostoma composed of ectodermal and mesodermal elements, typically present at inferotemporal limbus, and it is slow-growing, non-progressive. Clinical significance in pediatric patients: it affects the vision, like it induces astigmatism, it causes a surface irritation, and may be of cosmetic concern. Case presentation: a 9-year-old male child with well-defined and non-progressive swelling in the inferotemporal limbus right eye was noticed with no inflammation and no other symptom. Main concern was cosmetic. On examination, eyebrows, eyelids, eyelashes are normal. Conjunctiva is clear and healthy. Cornea is also clear. Pupillary reaction is normal and reactive. Extraocular movements are full and free. Visual acuity 6/6 both eye. No sign of inflammation, and fundus was also within normal limit. The characteristics of the lesion: it is firm to palpate, slightly raised above the surface, yellowish white appearance. There is no sign of inflammation, and it is non-progressive in nature. Differentials are Goldenhar syndrome. We referred the patient to ENT and orthosurgeon to rule out the Goldenhar syndrome. And they rule out the Goldenhar as there was no preauricular tags or any vertebral disformities. Then a surgery was planned. Complete excision was done under the general anesthesia, and the tissues were sent to the histopath lab. This is the sample. On histopathology, it shows the cyst cavity lined by stratified squamous epithelium with keratin flakes and fibrovascular tissues with congested and dilated blood vessels, and shows sebaceous gland and hair follicles. Postoperatively, we kept the patient for 24 hours and discharged in satisfied condition. 100% complete excision with no complication and 24-hour stay. Early recognition can prevent the progression and complications like astigmatism, and it will correct the aesthetic purpose of the patient also. Long-term sequelae prevention can be done if we intervene early, as it induces astigmatism, cosmetic disfigurement, ocular surface irritation, and visual development. Management principles: we should do thorough clinical assessment and do early intervention and collaborate with other specialties to rule out the syndromes. In pediatric cases, we should give special attention to development impact, like it will prevent amblyopia and refractive errors. According to literature, 95% is the success rate, less than 5% is the complication rate, and 85% is the cosmetic satisfaction of the patient. Take-home messages: we should intervene early to avoid the complications. Thank you.
How do you reconstruct the ocular surface after removing the limbal dermoid?
We just suture the conjunctiva.
That's all. If their deficit is much larger, in that case, what else would you like to do?
Ma'am, graft.
Which graft?
Ma'am, corneal graft. If we it occupies the corneal area.
AMT can be used if the
Yes,
conjunctival
ma'am,
deficit is more.
I'm not taking.
And then if what you are talking about, then it becomes a corneal case. You need to involve the cornea specialist as well, whether that site is perforated, depending upon how much thickness. Generally, it doesn't happen. Lamellar keratectomy is enough.
It is less than 2 mm. No, ma'am, it's not done. Actually, the child was not cooperative at that time. Thank you.
Thank you, Dr. Manjot.